Welcome to the Physio Discussed podcast, where today we will explore all things ACL, including the role of physios in managing ACLs non-operatively, the cross-bracing protocol, where do meniscal tears and osteoarthritis fit into the mix, and ACL healing. We are joined by Dr Kieran Richardson and Dr Stephanie Filbay. So welcome to you both, Steph and Kieran.
Thanks for having us on, Sarah. It's really good to be here.
We have plenty to get through today. So I think let's dive right in, starting at the role of physios in managing ACL injuries non-operatively. Can you perhaps elaborate on your thoughts on the key roles physios play in the non-operative management of ACL injuries?
Who would you like? Who should go first? I'm happy to.
The floor is yours, Steph.
Sure. All right. So I think the key role of physios really begins with discussing treatment options and discussing the evidence around treatment options, which we know doesn't happen very well, particularly in Australia where we're based and other parts of the world as well. So, I think it should be part of the physio's role to discuss the pros and cons of both surgical and non-surgical options, to provide an overview of the evidence and the likely outcomes that will occur with either treatments and how they compare. Should try to help the patient weigh up the pros and cons about which treatment route's best for them. So I think that's the first role in my eyes is around the discussion at the point of acute injury. And then they play a really important part, of course, in rehabilitation, right from the point of acute injury to return to sport, and then looking at prevention of re-injury or further knee injury and preserving knee joint health across the lifespan as well. And that's irrespective of if they do choose a surgical or non-surgical pathway.
Those are great points. And I think we'll certainly get to the OA component as well and preservation of the joint. Sorry, Kieran, your thoughts as well.
No, yeah, look, I would just reiterate and affirm what Steph's saying there. I think a lot of physios maybe can feel a bit out of the loop when it comes to managing ACL injuries. In Australia, a lot of the systems can be skewed towards early surgical opinion. And so I think physios really have to believe in themselves and see themselves as having a vital role. Timing-wise, we may have 30 to 60 minutes to actually go through all those options that we just alluded to earlier. And so I think if we can take our time and really walk the patient through all the potential outcomes, that helps. And then also online, maybe we can get into it in the podcast, but communication of those options online via social media channels, online websites, I think that's part of a lot of what physios can have a role in and help patients with.
So how do you both manage that discussion of pros and cons, particularly if someone's coming in with the thoughts of imminent surgery or there might not be any other option? What's the first step that you might go through? Is it looking at imaging, or is it more that subjective history, or what sort of things do you take into account when you're looking at surgical versus non-surgical?
Yeah, I'll speak from a research perspective, and I'm sure Kieran can speak from his clinical expertise as well. So we recently performed 2 Australia-wide surveys, one of physios and one of patients with ACL injury, to establish current practice and what was happening with the different healthcare professionals in Australia. And what we found is that most people didn't receive evidence-based advice about treatment options. And most of the time the advice is skewed towards surgery. So there's a lot of, persistent beliefs like surgery is the best treatment if you want to go back to sport. That isn't actually supported by the best available evidence. So then on the back of this, we developed an online patient decision aid, which is a resource that patients and clinicians can go to help synthesize the evidence around treatment options, the pros and cons, the risks and harms, because it is quite complex. There's a lot of research out there, and research sometimes it's contrary as well. So it is hard, I think, for a lot of clinicians to digest all the evidence, what is trustworthy, what's a robust research design, to then pass that on to patients. So that's what that online decision aid is aiming to do.
And where can we find that one?
So that is online at www.aclinjurytreatment.com.
Thank you.
Yeah, no problem.
And
Yeah,
Kieran,
so
your thoughts?
yeah, from a clinical point of view, like I said, I think I guess an important part of it is really taking our time. Oftentimes, if I see a patient who's already moved in to the traditional medical pathway, they'll often feel rushed and they feel like they maybe have to make a quick rush decision. And so once you start taking your time and letting the patient just relax and even talking about their goals, do they want to get back to sport? Is that an essential part of their life? Having a look through their MRI with them, because sometimes that's not even been explained to them. Talking to them about the research in kind of layperson's language, I think helps. And then just really trying to get them to cool their jets and know that they're not going to be worse off having waited. And even the topic of prehabilitation can be a nice one to kind of get them to just take it easy and not rush into things. But certainly, yeah, from our point of view, we see this really fast-tracked belief that the patients have to make a rapid decision, which I think is part of our role, is to take the tension out of that and just let them make their own decision ultimately.
Absolutely. And in terms of the patients that do end up going in for surgery before trialing that, either the conservative or the non-operative approach versus that prehab, what are the characteristics of the people that do end up going into early surgery? Is it largely the ideas beforehand, or are there MRI features that tip them into that early surgery category?
Yeah, I think if we sort of spoke about who's best suited to surgery, I think that's a different conversation than who goes on to have surgery, because often it is driven by misinformation. A lot of people think they need to have surgery in order to achieve their goals. So with that aside, in my opinion, who would be good candidates for surgery? So there's particular concomitant injuries when they're quite severe, like a bucket handle meniscus tear with mechanical locking, for example. And if we would typically go down the surgical route with some of those concomitant injuries, then we tend to refer on to surgery, and they often do undergo the reconstruction route. And then with elite athletes, it is a bit of you need to weigh up the timelines and the uncertainties. You know, it's possible to return to sport faster with non-surgical treatment, but if you go on to experience knee instability and require surgery, then the total recovery is going to be longer. And that's a risk for some people. So we'd be looking at things like key events or sporting events, you know, if there's a grand final or when's their season begin again. And often that's a key factor in thinking about which treatment option to take. You know, do they have 3 months to trial rehab first to see if they'll be able to achieve knee stability that way? Yeah, so it's not clear cut, but that'd be two of the key criteria in my eyes. Yeah.
Fantastic.
Yeah, I guess following on from what Steph said, you'll get some patients who already have a fixed view that they need surgery. So in research, they would lack equipoise, would be the term in air quotes. They've already made up their mind and maybe can't be convinced otherwise. So those patients they're on a one-way ticket to surgery because that's what they believe they need. And then clinically, probably what I would use as some markers would be sensations of instability despite having completed a 3 to 6 month rehabilitation program, or they have no evidence of healing on follow-up MRI with a desire to return to high-level pivoting sports. These people may still be able to cope, but I guess the risk is going to increase that giving way episode. And particularly if that's their main driver is to get back to the higher change of direction level sport, then we could be putting them at risk of more cartilage and meniscus damage. So yeah, those are probably some of the key things I'm looking at.
Yeah, so I was more discussing the acute ACL rupture, but absolutely, I think any persistent instability despite trying rehab is a really strong indicator that they benefit from surgery. That's what the recent Lancet RCT, the SNAP trial showed, that surgery is more beneficial than rehab for that group that have persistent long-term knee instability. We really want to protect the knee from recurrent instability and further knee damage. So that's a really good group that are great candidates for surgery. Yeah, I agree.
And is that sort of criteria of persistent recurrent instability, is that measured purely subjectively? So someone will describe, I was playing basketball and it gave way.
Yeah, so we are talking about instability, which isn't the same as passive knee laxity. So knee laxity is assessed with Lockman's pivot shift tests or arthrometers, and that's actually poorly associated with functional stability. So whether the knee is stable during sport or activity. And the reason why we assumed was because of the neuromuscular control that can happen to the joint. But potentially now we know that there may be a role of healing of the actual ACL in those people as well that might be contributing to more functional stability. So it should be driven by functional stability, whether the knee is stable, whether it's perceived to be stable and is actually stable during activity. Also, I think it's a little bit of a cop-out when we say, oh, people can learn to cope with an unstable knee, they can just give up sports and walk in straight lines and they'll be fine. In my eyes, we should always be aiming for a stable knee. Like, who knows what life's going to throw at people? They want to be able to run for the bus or play with their grandkids. So I think we're trying to achieve a functionally stable knee, irrespective of treatment pathway.
Yeah, and some of the patients, when you've seen a lot of these, some of the patients will early on have sensations of instability, they will term, but it's not really a true episode of hard instability where the knee collapses underneath them, they feel a crack, their joint swells up. And that can just possibly be part of getting used to having recovered from an ACL injury, their quads being inhibited, their ACL not healed yet. And so we can't really say that if in the first couple of weeks you've felt instability since the incident that you're definitively going to need surgery, because there's lots of cases where the patients will go on to have a stable knee, functionally, as Steph said, and confirmed on MRI with a healed ACL. So yeah, I think the real key thing is getting these people to access someone who's experienced and trained in communicating all of this information, but then getting them on a solid rehab program or bracing program, and then following them up with, as a part of a multidisciplinary team.
Yeah, it's a good point. We really do need more effective ways of clinically assessing functional instability. And that isn't, as Kieran said, from week 1 or 2, because it's inherently unstable at the time of ACL rupture, and then there's a progression in terms of recovery. So at what point and what stage should we be assessing that, and how is it best assessed? We don't want to ideally assess that on the sport field or on the footy oval when they can have a gross episode of instability. It's best to assess that earlier, but we do need better ways of doing that.
Yeah, and just one final point on that. I've seen a few patients who've gone to see someone who's maybe more encouraging early surgery, and so if they've had their recent injury, they then have their ligament assessed. It does feel lax, and they can say, well, your joint is lax, that you are unstable. So they will put that onto the patient. And as Steph said, that's a problem a few ways, because that ligament could actually tighten up over time, and then at a future time point may be more stable passively. But there's also, the best research shows that doesn't predict the person's ability to function in weight bearing just in normal day-to-day life, but certainly with sports as well. So it's a bit rough to put that onto the patient early.
And it's also, I'm sure, quite hard for the patient to define is the episodes of instability. All they know is it doesn't feel nice and it feels like it's going to collapse. But is it what our definition of it's very patient dependent, and it's picking what's important to them as well, which, as you say, it's about being goal focused.
Yeah, we do need to tease that out a bit because, you know, you have muscle inhibition and buckling of the knee. You can have concurrent patellofemoral pain, which can cause sort of buckling in the knee with stairs and that sort of thing. Even a small effusion in the knee can cause that sensation as well. And that's not really what we're after here. It's more of that gross multi-directional instability causing a giving way episode. So it's teasing that out around the subjective assessment as well with patients.
Well, on to that then, Kieran, you did allude to the cross-bracing protocol. So I'm curious as to what are both of your perspectives on the use of the cross-bracing protocol for non-operative ACL management. Steph, I know you've done plenty of research on it as well, so I'm curious on your thoughts too.
Yeah, I mean, so we're currently conducting a national multi-site randomized control trial that will compare the cross-bracing protocol to early ACL reconstruction in 180 people. So we'll look at 8-month outcomes in particular in terms of self-reported knee function, quality of life, pain. So that's the design we really need to evaluate any treatment compared to another treatment, because all other research designs are subject to, you know, inherent biases in the design. But with that aside, I mean, a lot of treatments we currently use, and particularly the majority of orthopedic surgeries, don't have clinical trial evidence to support their use. And what we're talking about here is a lower risk or less invasive option than surgery, which we know around 90% of people in Australia have. So as long as our patients are informed and they understand where the evidence is at and what evidence is available at the moment, and that they understand, you know, with any non-surgical treatment, not everyone will have a successful outcome, and some people then will be recommended surgery, so they understand that, and they understand what it involves as well. Then, yeah, I mean, I think it's an attractive treatment option for lots of people. They like the idea of trying to see if your ACL will heal first before considering surgery. And the preliminary research shows that healing rates are a lot higher with this bracing protocol compared to just rehabilitation alone.
Fantastic. And can I clarify, and for those who are not familiar with the cross-bracing protocol, do you mind just running through sort of the key components of what rehab looked like for those participants?
Yeah, so the bracing protocol is most effective for people within a short window after ACL rupture, no longer than 3 weeks, but ideally even within 2 weeks, while there's still that acute inflammatory response in the knee. So they wear a knee brace that is locked at 90 degrees flexion. And the reason for that is that at 90 degrees and greater degrees of flexion is when the two ruptured ends of the ACL are closest together. So it uses like those orthopedic principles of reduction and fixation, and that's the idea behind it, to help facilitate healing. Then at weekly increments, after 4 weeks, the braces allows more and more range of motion until full range of motion at 10 weeks, and then the brace is taken off at 12 weeks. During that time, they're performing intense physio-supervised rehab, even when the brace is on and even at 90 degrees flexion. So even in those earlier stages, they're doing, you know, with their knee at 90 degrees, wall squats, bridges, isometric co-contractions. And a really important piece as well is around DVT prevention. So that typically on DVT prophylactics whilst they're non-weight bearing in the brace. And then once that brace comes off, it's performing the typical ACL rehabilitation in line with best practice until they return to sport.
Fantastic. Thank you. And Kieran, your thoughts?
Yeah. So look, I think it's been a real positive for the cross-bracing protocol to hit mainstream. And obviously there's this large cohort now that have gone through, you can correct me if I'm wrong, Steph, but I believe it's over 700 people now, which I think is fantastic and amazing for patients to be aware of this concept that the ACL can heal. And for the researchers and clinicians who've undertaken that, and then the RCT to come, I think that's magnificent. And it's really only going to be better society, I think, for having that present. So I think on the whole, it's been a positive. The challenges I think it brings is we've got to be careful to avoid a binary thinking that it would be, which I've seen a bit online and in discussions in different social media forums, that it's cross protocol or reconstruction, where there are groups of patients that are going to do very well, just as well, with rehabilitation on its own, or with maybe a more modified bracing protocol. But scientifically, what we need to work out is prospectively randomizing each of these cohorts. Ideally would be the ultimate scenario, so we can kind of work out what type of tear needs what type of treatment as soon as possible. And so I think in an ideal world, that would be what we would have known. Ideally, we would have known it 60 or 70 years ago, when the theory that ACL tears could never heal began to be propagated. But I think on the whole, having these types of bracing protocols available to patients is only going to be a win. And so, yeah, I think it's just then the clinicians and researchers working together to try to be as balanced as possible, presenting all the options to patients, like we said at the start, and then finding your team. If you're a clinician, I tend to find, speaking directly with Tom has been great, and then surgeons who advocate for this view as well, and then having expert clinical non-surgeon specialist physios, these kind of things, is been really helpful to have that team of people who are able to deliver the information to patients. So that's, yeah, I think on the whole, it's been great.
Yeah, so in relation to who's most suitable for which treatment options, for decades now, researchers have tried to predict who will become a coper with non-surgical treatment, but we've really learnt very little over the decades. And so at the moment, we can't determine based on characteristic who's a great candidate for surgery and who isn't. But now that we know that ACL can heal, it brings new opportunities to try to understand who is best suited to non-surgical treatments. So at the moment, we're now looking at predictive models to try to understand who's most likely to achieve optimal healing. Because we know not all healing is the same. There's variations in the quality of the heal, from thick, taut, normal appearing ligaments to ones that could be thin or lengthened. And something we're finding in clinical practice that we're now exploring in research is that the severity of the disruption to the ACL at the time of ACL rupture is likely related to healing potential. So variables like the gap distance between the ACL, whether the femoral origin is pulled off the femur and avulsed, the degree of disruption of the distal portion of the ligament, so whether that's flipped and lying horizontally on the tibia, for example. And there's other variables as well as some patient characteristics that we're looking at in that predictive model. So in the near future, we may be able to say, someone that presents with these characteristics is a great candidate, for example, for the cross-bracing protocol. It could be that the least severe ACL ruptures will have successful outcomes irrespective of any non-surgical treatment with rehab or even no exercise. And then it may be that the most severely disrupted injuries are the best candidates for surgery. So hopefully we'll have those answers in the near future.
That's fantastic. It's often the case that there's just far too much heterogeneity amongst all the participants, isn't it? It makes it really hard to make a clear-cut decision.
Yeah, and I guess the other point as well is that, at least for the patients that I see, my cohort would typically be general population. I have some elite athletes, but even if the ACL doesn't heal, it's not the end of the world. So some patients can get really distraught or be told because it hasn't healed that then it is a necessity that you have surgery. And I think that's wrong. And so we need to be communicating also just what can happen if it doesn't heal and what that means and what that might mean for you. And so as good as the healing topic is, I don't think it's necessarily the end of the world if it hasn't healed for a lot of patients. And we can maybe unpack this topic, but this idea of adapting, where a lot of patients, probably in the grand scheme of things, if they're thinking about it, maybe returning to high level pivoting sport is not the smartest or wisest idea. And so when they hear that and when they contemplate that, and knowing that a lot of patients who undergo reconstructive surgery will never get back to their pre-injury function, if they knew that, well, maybe, and they could reflect on, well, if I could go for runs, if I could do lower level skiing, if I could do some CrossFit, and for them that's going to add meaning to their life, and they can do that without an ACL, they'll be cool with that. And so that's another part of the picture that I try to communicate early. I'm not sure what your thoughts on that are, Steph, but
yeah, I mean, I still think outcomes should be driven by knee function, so it shouldn't be driven by the healing status. We were all taught as physios that, you know, a knee can become stable with neuromuscular exercise as the muscle and the brain learn to cope without an ACL. But those studies haven't looked at healing status. So we can't yet tease out the role that healing was playing in those non-surgical cohorts. But I think it's likely that some people do and can have a stable knee with no ACL healing. And there's likely to be a continuum, you know, perhaps there's ACL healing and instability, especially if it's thin or elongated. So another area that needs more research, how those variations in healing relate to differences in knee function. But again, you know, so it shouldn't be, can you just not return to sport and do CrossFit instead? It should be, is your knee going to be stable enough for you to function throughout your life in all the activities you want to be able to do, you know? Yeah.
Those are some fantastic points. And I think, what would you suggest for the clinicians out there that have an ACL come in tomorrow and they have to present the non-operative approach, the cross-bracing protocol, and surgery? Do you typically present those three, or how do you navigate that discussion best, or what would you suggest for a physio for tomorrow?
Well, yeah, that's a really good question. So through work I do for the Australian Physio Association, but also through my company, we're trying to train up physiotherapists in the research literature and then how to practically roll this out with patients. And so obviously it's wrong to hem a patient into a single decision. But simply a lot of the physios just are becoming aware of this research and don't know how to synthesize it rapidly to a patient. And so in my experience, and I would recommend reaching out to someone that you know has gone through this a lot. So whether that be a researcher who I know a lot of the researchers are very open to sharing the knowledge and papers, or expert clinicians, people who've gone through it before. Certainly if it's your first one, I would suggest do not go alone. Like, you should have someone who's walking the journey with you, who's more experienced and trained. And then it needs to be a part of the initial conversation. And the resources, we've got a Facebook group that's got almost 25,000 members on it. So you can allow, it's ACL and meniscus tear recovery without surgery. Directing patients to communities like that, I think, can be really helpful, where the communication is balanced and evidence informed. And then, yeah, like as I said at the start, trying to get the patients to just take their time and just relax and think through everything first would probably be where I'd start.
It's fantastic advice. And Steph?
Yeah, again, from a research perspective, we're working on developing core capabilities that physios need to deliver high quality ACL injury care across both non-surgical and surgical management. Because I think that's needed. We need to first define, what does this look like and what are the skill sets that physios need? So then they can identify where they need to upskill in order to be able to manage people effectively and in line with the evidence. Because we know not all management does reflect evidence-based practice. There are some great clinicians out there, and there's others that probably could do with upskilling in order to manage people effectively. In terms of your initial question around the 3 treatment options, if you see it like that, well, I'd first be having the discussion around rehabilitation as a first-line treatment versus early ACL reconstruction, as they are the main two treatment options with clinical trial evidence. So I'd be summarising that trial evidence, which resources like our decision aid will help to do that. And then if you are trained in delivering the bracing protocol, it's complex. It's not something that anyone can just do because it has important medical considerations like DVT, prophylactics, and eligibility for that brace. If you were trained in it, then that could be a separate discussion that, you know, well, there is this new treatment that's being used. This is the research available at the moment. You know, these are the pros and cons of that treatment. And if you want to have further discussion around that, we can go into detail. But I'd be providing the main two options first before talking about, you know, other less mainstream treatment options.
Just another point I wanted to add, if I could.
Please.
Obviously, we have this acute communication and management, but the reality is we're going to be seeing these patients for a while. And so there's a paper from 2017 here in Perth, Jay Ebert, who's a researcher, where a lot of the patients who have reconstructive surgery, 9% of them don't get any supervised physio at all. 45% of them after 3 months aren't attending any supervised exercise, and only 30% of them actually perform agility and change of direction training. So one key thing is that patients know that it's something that they have to check in at various time points, and it is a bit of a journey. So although we're communicating these options, they need to know that whatever path they choose, it's a pretty extended journey. It's not a quick fix. No one's going to have a quick fix, but I think some of the patients can be left with that impression. And so the clinicians, physios, need to be confident to continue to follow the patients up, whatever they decide to do.
It's I think those are all great points, and it's sounding like, on the whole, zooming out, whether it's an ACL, it's a shoulder, it's an ankle, whatever it is, it comes down to those setting expectations. Are we educating patients well, and are we aware of our own gaps and how to actively seek to fill them? And then are we seeking that multidisciplinary approach where it's indicated? So moving on to meniscal tears, which, Steph, you mentioned earlier as well. So what are your thoughts on where meniscal tears come into both either the non-operative management and the operative management of the ACL tears?
Yeah, so in most cases, I think that meniscus literature is very similar to ACL literature in that trying rehabilitation first is a good option for most meniscus tears. We still tend to agree that the exception is mechanical locking with a big bucket handle tear. It's not really supported by the research, but it's kind of a given that we say, okay, let's refer that on to surgery. So in the bracing protocol, over 50% of people in that BJSM publication had meniscus tears. And then at 3 months, when the brace came off, all except one were asymptomatic. And only one of those 80 people went on to have meniscus surgery for the baseline meniscal tear. Yeah, so there's a few clinical trials now showing that surgery is no better than rehabilitation alone, particularly in the long term for meniscus injuries. So again, I'd be typically trying rehabilitation first, but if there's persistent issues, then surgery is a great option.
Fantastic. That all makes sense, I think. And Kieran, your thoughts?
Yeah, the meniscus tear topic is a bit of a challenging one. Having been a part of interprofessional conversations, discussions, and scientific debates, there's almost a bit of a clash of paradigms, because you have the research evidence, which we can interpret, and we're looking for the comparison arm. If there's a surgery, is there a comparison arm, full stop, but is there a high quality rehab comparison arm? And then you have the almost traditional orthopedic view, which if you speak to a lot of surgical advocates, they would be saying, if there's a meniscus tear that's repairable, I need to repair that. And I'm not going to do that without a reconstruction. And so for the patients, they can sometimes be caught between those two worlds of what the research says and then what might happen in a traditional medical model. And so practically, I think for the exercise therapist or physiotherapist who's viewing a patient, I think it's important that we are communicating to patients that a large proportion of these meniscus tears can do very well. Either they may heal on follow-up scan or they may become asymptomatic. And so in the reality that we may be the only clinicians who are actually communicating that to the patients. And so the presence of a meniscus tear with an ACL injury, as Steph said, I think the displaced bucket handle tears, clinically I've seen them, the patients won't be able to straighten their knee, they will need surgery. But it's these other tears where it's more up for debate. If I leave it, what's going to happen? Will I get arthritis? The traditional orthopedic view is the repair of the meniscus will reduce the risk of arthritis. And meniscectomy, if it's indicated, if the patient's got locking. But the research shows that repairing the meniscus may not necessarily have a role in reducing arthritis. And a lot of patients, if they've got symptoms of locking, if it's not the meniscus isn't displaced, can actually do just as well with an exercise program. So yeah, I think the meniscus topic is challenging because we're often coming up against the evidence, which is different from what we've always believed the way meniscus and menisci should behave. If that all makes sense. Yeah.
Absolutely. And we can see why change and that translation of research into practice can take so long, because there's so many factors that we're working against as well, I suspect. Steph, I'm curious, in that study of the patients that became asymptomatic, did their meniscus change much on imaging post?
Yeah, so for quite a few of those, the meniscus tear was still visible, or some change in the meniscus was still visible at 3 months, but they had no knee symptoms. So yeah, again, it should be driven by symptoms and function, I believe. And another challenge, though, is, you know, with people with concurrent meniscal and ACL ruptures and meniscal tears that maybe have a bit of an unstable knee fairly early in their journey, what contribution is the meniscus contributing to that knee instability or that sensation of instability? You know, people with isolated meniscus tears can have sort of giving way, catching, locking feelings in the knee. So that's kind of difficult as well to manage and to tease out what's going on there.
That's a fair point. And I suppose going on from what you were both saying with regards to that orthopedic theory of the meniscectomy or addressing the meniscus in the prevention of osteoarthritis, I'm curious on both of your thoughts as to where osteoarthritis comes into this discussion in ACL rehab.
Yeah, with meniscectomy, that's a bit outdated now. I think it's been shown to increase the risk of osteoarthritis, and it's the main players are meniscal repair or still meniscus resection, with the best results out of those typically being meniscus repair if it's viable. In terms of osteoarthritis, you know, the research has definitely debunked the long-held belief that surgery reduces the risk of osteoarthritis. So there's now systematic reviews and umbrella review, which is basically a systematic review of all systematic reviews, showing actually higher rates after surgery in terms of radiographic osteoarthritis. So that's changes that we see on X-ray, but that doesn't necessarily correspond into symptomatic osteoarthritis, which is one of the key limitations we have in a lot of OA research, is that traditionally people have just focused on radiographic, which we know is poorly associated with symptoms. So I wouldn't say surgery increases the risk of symptomatic OA, but it may accelerate some of the bony morphological changes. and that's now been shown on a number of studies, which has found more rapid bony changes and a prolonged inflammatory response after early surgery compared to rehab alone, or compared to doing rehab, waiting, allowing the knee to come down, having delayed surgery. So there may be something about the surgical procedure in itself that predisposes someone to post-traumatic osteoarthritis.
Mm.
Yeah, so from a research point of view, Steph mentioned these empirical studies. So there was one just published, a systematic review by Catherine McIntosh from New Zealand, showing that very similar rates of osteoarthritis. Hewitt and Webster from 2022 and Ferrero, from 2023, both showed slightly increased risk of osteoarthritis with reconstruction compared to rehab alone. I guess practically you kind of have these two views. So you'll have the view for surgery is that if you don't operate, your ACL won't heal. You'll get additional meniscus tears over time, and then your knee will basically become arthritic. And then you have the other view, which would be against surgery, which would be the procedure itself is drilling into the knee joint. It's softening the cartilage. It's changing the shape of the bone. It's causing inflammatory markers. We see that with patients post-op. Their knee looks more swollen than before they've gone in. And so I think for patients, we can kind of take this middle position where we say, well, look, from a research point of view, there's no, because I think there is this pervading view that put forward that if we don't operate on the knee, the patients may progress to get early arthritis, and in fact get a knee replacement. And there's this paper from 2016, Sanders, that's often bandied around in discussions where if you look into the quality of the study, it basically compares reconstruction to nothing, or to no high quality rehab. And so we can tell patients with confidence that they're not at increased risk of developing arthritis if they delay reconstruction. And so when I'm having that conversation with patients, giving that information to them is quite empowering, I think, and can cut across maybe some misinformation that they're told that if they don't rush into getting surgery, they're going to end up in a wheelchair or have a total knee replacement, which I've had patients told, which is borderline fear mongering. And I think it's for the patients, it's quite distressing. And so yeah, we have these views, but then communicating the empirical in an understandable way to patients is I think key.
Yeah, two key risk factors of osteoarthritis is meniscus injury, or a graft rupture, potentially revision surgery. So we know that people who tear the ACL graft, 90% of the cases, they also injure their meniscus and cartilage or cartilage. And people that have revision surgery have a much higher OA risk than the first primary surgery. And if a patient has an isolated ACL tear, that has a lower risk of OA than meniscus and ACL tear. And so we're really trying to prevent additional knee injuries, irrespective of treatment, surgical or non-surgical, as well as preventing graft ruptures as well. So I think it's sort of also agreed if someone had persistent instability, that's going to increase your OA risk. So we want a stable knee. We want to protect the knee from further meniscal damage and graft rupture. And one of the key risk factors for further knee injury is returning to high-level sport. So that's where the patient should be informed. If you do return to sport, your risk of re-injury is higher. And if you were to re-injure or to tear your graft, this is what that might mean for you and your long-term joint health.
A fantastic segue into, I think, return to sport rates as well. What are the sort of discussions that you typically would have with your patients around return to sport, and how early do you have those discussions?
Yeah, so return to sport is a common area where patients are often told that, surgery is needed to return to sport. So we'll be publishing in the next few months, the paper's under review at the moment, a systematic review and meta-analysis comparing ACL reconstruction with rehabilitation alone. And what that review will show is that there's no difference in return to sport rates, whether you have surgery or rehabilitation only. And not just that, but there's also no difference in the level of sport returned to. And that's despite the fact a lot of studies in that review actually advise people that they shouldn't return to sport if they have non-surgical treatment and encourage the surgical group to do so, or they intentionally chose surgery for those who wanted to return to sport. So even considering those factors, there's still no differences in rates of return to sport. So I think it's incorrect to be telling people that if they want to go back to sport, they should be having surgery.
I look forward to seeing that paper. That's fantastic to see.
Yeah, I mean, me too. So I think as well, really with patients, especially if they're going the non-surgical route, which I oversee a lot of, there's a couple of different characteristics I'll see with patients. I call it going rogue, where the patients have basically just decided that they want to run their own journey, and they're not interested in getting supervised rehab. And those patients are obviously going to be at greater risk because we can't control what's going to happen with their knee. There's no assessment. And so by not having surgery, it doesn't mean that you just, we're going to fast track them and they're going to be going through some independent program. It still has to be structured. It still has to be criteria driven, has to be scientific. It has to be intense. And the worst thing that could happen in the non-surgical pathway, and if it's the patient that's driving that, or if it's the physiotherapist who's not trained, the patient could go back to sport, have a giving way episode, and then have a large meniscus tear. And it's pretty hard to argue. You would have egg on your face and basically be seen as, well, I told you so. That was what's going to happen. But the reality is, it needs to be controlled and it needs to be overseen and supervised. Equally, with surgery, we don't want these patients rushing back if they've had the surgery, if they haven't gone through a criteria-driven rehabilitation that's supervised, they've passed their return to sport tests. And there's some research which Steph may be able to pull. But basically, a lot of the patients aren't passing these return to sport tests. They're not going through their psychological readiness. We definitely know from research with surgical cases, if they are fast tracked, they're at much greater risk of re-injury. And so, yeah, these patients need to be supervised in either group, and be aware of their risks of re-injury as well.
Fantastic. Yeah, and around timing of return to sport, considering as well biological healing, either of the native ACL if you're aiming for that, or the ligamentization process and biological healing of the graft, which is still occurring 18 to 24 months post-surgery. So even if you feel good and feel ready to return to sport, there may be benefits from prolonging that and continuing your rehab, because there may be things going on inside the knee that people aren't aware of, that might increase the chance of re-injury if they return early.
Fantastic points. And you've both mentioned sort of criteria-based assessments. And Steph, you've mentioned several times the function of the knee. What sort of assessments do you both put your patients through to determine whether they are ready or not when they have gone through that biological healing time?
Yeah, I mean, there's a lot of assessments that you would do. Certainly, there needs to be some strength assessments of the lower limb. There needs to be some psychological readiness assessments. There needs to be graded return to sport assessments and HOP tests. So those would be some of the key metrics that I'd be looking at.
Yeah, there's now a lot of good guidelines available to direct that. So the ASPETAR ACL rehabilitation guidelines are a good one. It's developed for post-surgery in particular, but there's nothing to suggest that there's any differences in terms of criteria that we're trying to achieve post-surgery or with rehabilitation alone. So I think that's a good resource that can be applied to both treatment arms.
I think that's all fantastic advice. And before we wrap up, I'm curious if each of you have perhaps one key takeaway for our listeners that you'd like our audience to remember when it comes to non-operative ACL management.
Yeah, I would say inform patients of the evidence. If you're not aware of the evidence yourself, then upskill or refer on to someone who is, because it is really important that they receive accurate information about their treatment options so they can make an informed decision that aligns with their values and life priorities. At the moment, a lot of people don't have the chance to make an informed decision. For that to happen, they have to receive accurate, evidence-based information about their treatment options.
Great advice, Steph. And Kieran, your key takeaway.
Yeah, look, it's been quite fascinating to watch, particularly this ACL healing topic unfold. And I had this Scandinavian patient who went and sought an opinion from an Italian surgeon who said to her, "We're coming to terms with the reality that ACL tears can heal." And I thought that was quite funny, almost like a grieving. But yeah, so I think as cool as it is to see a lot of this research come out, and the healing comparison studies before and after, it's pretty amazing. But if you're not sure what you're looking at on the first scan, and if you've never taken someone through non-surgical, there are risks associated with it. There are potential harms associated with it. And if you're out of your depth, there's potentially medico-legal risks associated with it. And so, yeah, it's, as Steph said, it's important that you get training, that you're across the breadth of the research, and your information that you're communicating to patients is accurate, balanced, unemotional, and, putting the patient at the center, patient-centered. So yeah, that would be my key takeaway. Yeah.
Wonderful advice. Well, thank you both so very much for giving up your time to discuss a really important and valuable topic. I think our listeners will get a great deal out of today's discussion. So thank you.